So I'd like to hand over to Catherine Gamble, who's going to be chairing this event for us. So Catherine is the Head of Nursing Education, Practice and Research at South West London and St George's Mental Health NHS Trust. And at the time the pandemic began, Catherine was also the RCN Professional Lead for Mental Health Nursing. So over to you, Catherine.
Thank you so much, Sarah. I'm delighted we've managed to attract so many people to attend this session this evening. I'm delighted to be able to be interviewing two of great colleagues, Douglas and Roland, and I'm making no excuse of the fact that when Sarah approached me, I wanted to actually get male perspective, because I was very mindful that as a mental health nurse, we rarely get the opportunity to hear the male perspective on the pandemic and also the impact that that has had. So I'm looking forward to speaking to them both. First of all, I'm going to talk to Douglas and then obviously follow up with Roland, who many people will know through the NAPICU and his work with the intensive care units across the country. So, Douglas, do you want to join us?
Hello, Catherine. Hello, Kath, how are you?
I'm all right, thank you very much. And I'm delighted you've been able to join us, because I want us to talk through and share what we, how this all came about. I mean, I just remember sort of around February time talking to you about digital work and IT and things around, because you're a very active member of the RCN forum and as an RCN activist. And I remember very clearly wanting to have conversations with you about digital technology. And little did I know that moments later we would be jettisoned into a digital technology that I had never had to experience before. So just to start off, well, what was your first memory?
Sure, I think the first actual memory was in the run up to Christmas. And I was having a conversation with my partner about Christmas presents and whatnot, and then the news flashed regarding a viral outbreak in some part of China at the time, I think Wuhan. So we didn't know too much about the details. It was sketchy, and we're kind of thinking, okay, just see what happens, see how events will transpire. But we didn't pay it too much mind, because I think China is probably 6,000 or 8,000 miles away. It's going to be in hand, and that was it really. And besides that, there was not a lot of guidance coming from the government at the time. So that was the first memory I had of it. I didn't pay it no mind. Then subsequently, after Christmas, things started ramping up, particularly in January, February. The news started becoming a lot more coherent. And then people started thinking about what are the implications of that. So yeah, early on pre-Christmas, and then certainly after Christmas, a couple of months after Christmas, that's when it really started to hit home.
Yeah. So what was your initial reaction? You just talked a bit about it being, but what did you feel like? What was your reaction?
Okay, the first reaction I had was, okay, this is now when things are getting serious, February, March. I think the government is about to start announcing, or at least there have been the pressures on the government to come out with some sort of guidance to the population as to how to manage the situation. So I was terrified. I was thinking, okay, pandemic. I've read about these things in history. It wipes out a lot of people. What do we then do? Which roles are going to be most in demand? And then you think now clinically, how then are you going to be managing patients within such an environment? You know, I knew straight away that they will have to draft people in from all sides, out of retirement, bring them in, students studying health and social care need to be brought in. I knew if it gets big, as the news was starting to inform us, I knew something was coming. And at the same time, I was confused, and not confused in terms of how then do I respond to my family, both the family that in the UK and my family in Zimbabwe. How then do you have the conversation? Because they're phoning me up thinking this is not a problem, and I'm realizing that this is a problem. And how do I pacify everybody else and and be seen as somebody that is a good signpost of information. As a clinician, as a mental health nurse, you know, one of the primary functions we have is to be able to signpost people to information. So as I was doing shifts on telephone support services for the single point of access team, questions were being asked by people in the community who are calling up for emergency care in and around their mental health, and they were confused. And some of them were actually drawing parallels to the pandemic at the time. So, but then being not in a very strong position to give them the right advice did concern me. It did concern me a lot in those early days, in the earlier days, yeah.
I remember being at the RCN, and my colleagues who are in infection control and public health professional leads really talking in a language that I had never really heard. You know, I didn't know about donning and doffing and PPE, and I suppose, but I wanted to just ask you about, because you were in an agency position, what was your role? What was your response?
Well, the agencies, as you know, it's a double-edged sword, because what tends to happen is when you support in your clinical activities through agency work, you always have to balance up accepting shifts and knowing if you don't accept a shift, you might not get offered a shift further down the line. So there's less security around your role. So as the month started to tick on, March, April, May, the first lockdown kicked in, agencies were calling me, and I'm a member of numerous nursing agencies, all calling me off the hook. We need you on shift. We need you on shift. We need you on shift. So there was a lot of pressure. One, there's the economic, financial one. If it wasn't a pandemic, you earn a lot more money because there's shifts coming in. At the same time, you've got to think about your own safety and the safety of your loved ones at home. So you got that pressure as well, but there's shifts at the same time. What do you do? As you rightfully said, Catherine, we had a conversation about PPE. I felt de-skilled. Overnight, I felt, bang, my skills are no longer really, really valid in terms of this physical health direct care, which I've studied, but then it was always a light touch. But as I think Roland will explain further down the line, being able to manage people when there's a pandemic is very, very complicated, particularly people with learning disabilities, particularly people who are of older people as well, and they come present with their confusion as well. These things were really presenting a lot of challenges. So the first thing was, overwhelmed. I need to get myself up to speed straight away with the latest guidance. That's the first thing I wanted to get done. And I searched high and low for information that is related to mental health in and around the pandemic. And as you can imagine, scant or nothing was there.
I remember at the RCN, we went into absolute overdrive. I don't think some of the professional leads slept for at least 2 weeks. They were absolutely on it to give as much information as possible. And I remember being very humbled by just how hard they were working to get out a message. I think do you remember how your colleagues were responding? Do you remember how people were with you? Yeah,
there was a lot of support from permanent members of staff when they see you coming in and supporting them with the shifts. There was a lot of that support, but there was also an air of despondency as well. Mm-hmm. Some felt pressurized that they have to be on duty at the same time. And what I need to bring to the fore here is when this pandemic was emerging, there was a lot of information slowly starting to feed into the press in regards to who is most at risk. I think that's the number one question. Who's the most at risk? Pandemic. And then outside of the age bracket, it started becoming more granular in terms of, okay, we're getting reports that BAME staff are more susceptible to this virus. So I was having and witnessing colleagues break down, cry, feeling overwhelmed, and most nurses, we get into this profession to help. And that really cracked a shell in a lot of people, in the sense of at what cost? At the cost of my own life, at the cost of potentially bringing a virus into my own home. These were real issues that were being discussed openly. I've seen staff go home, just couldn't take it. At the same time, you know, most and quite a lot of BME staff have family in diaspora outside of the UK that they are either supporting directly, or at least they're missing back home, grandparents, parents, and whatnot. So that was a hidden battle, I think, clinically, that was being fought at the same time as the whole team, whether or not you are BME staff, you're still all going through your own issues as well. So there were these fractious undercurrents of emotion that was bubbling, and it was not conducive to delivering the better care. It was not conducive, but I guess it was the outpouring of emotion that had to go somewhere. And I know, Catherine, you're a big believer of clinical supervision. And I remember that I was thinking, I don't know what if Catherine was there, supervision, how can you supervise everyone on every single shift? Because this is what was happening on every single shift. People are in despair. And that's something even now when I think back at the situation, it's bizarre. It's you couldn't make it up. You just couldn't fathom it. It was coming from all directions, and even solidarity amongst your peers, your colleagues that you've trained with for a long time. When it comes to now direct care of a patient, what then do you do? Who's going to be in the front delivering that care? You know, so it's tough. It's tough.
Well, that's deliberately why I've asked men to be involved in this interview, because I'm very mindful that as mental health nurses, we are encouraging people to share and to ventilate their concerns. And I was very mindful when we were talking about how to support each other. And I know that the females in the team I worked with at South West London and St George's were very quick to say and talk about their vulnerability. I just wondered how you managed as a male nurse, how that impacts, and how, you know, what forums did you use, and what sort of conversations were you having with colleagues?
Okay. Outside of the lead role we play within the RCN as mental health leads, I also, many moons ago, I had an idea, let's bring together the Zimbabwean nursing community together, So it's created the Zim Healthcare Association with my colleague Bruce Mvura. So what was happening was, on that Facebook page, there was a lot of questions coming in terms of, what do we do? What's our position as Zimbabwean nurses? What can we do? And I was engaging with other BAME nursing groups in Ghana and Nigeria. We're having these conversations that were taking place. And at the same time, the dentist group was starting to come about. So these conversations were becoming far more fluid, and I was feeling more confident to talk about it. And as the little platform I have, I thought, let's use that platform to raise awareness as much and support each other. I was approached by the BBC in an interview piece, to talk through about the challenges around PPE, agency working and whatnot. So I done that interview. I expressed how we felt. We shared it on our platform. That stimulated a lot of discussion and hopefully change, because some trusts felt they were incapable of addressing some of the challenges BME staff were having, some of the challenges around PPE as well. But in not hiding or assuming the ostrich position and being proactive, some trusts actually went over and above the national guidelines to help and not only create an environment whereby staff felt supported, they felt valued, they felt like they're in it together, not being overly exploited out of the situation. And also hearing from loved ones, I would say loved ones, either ill with the COVID, or even when I think we spoke the other day about the first cough, when you have your first cough, you're thinking, what do you do with this information? It's a cough. You need to get tested. When can you get tested? Remember, as an agency worker, things are not very clear and straightforward. Your permanent staff, you know where to go and all these things, the provisions have to be in place. In mental health, there's a great reliance, particularly in London, inner London, with agency workers. So without the coordinated response from all agencies together to say, look, this is how we're going to support all agency workers in terms of upskilling your training, making sure you get PPE, that I didn't feel was done. That's one of the things I always think back. Yeah, you could put bodies into wards as an agency, collect payment, but there were a lot of gaps in the staff that was sent out in terms of their ability to confidently deliver care. I'm not sure if I answered all the questions in there. It was a bit easy.
No, but I was just thinking that I remember that BBC interview being really pivotal, particularly around talking about the vulnerability of BME staff, and also remembering the very powerful thing you said on that BBC news. You were on at 6 o'clock and at 9 o'clock, the main prime time television, saying actually you were going to withdraw your labour because of that fear. And I was so struck by that, and the conversations I had with other BME nurses who were really very scared indeed, and continue to be so. Let's not say, this hasn't gone away. This was the first round. But I remember everybody feeling incredibly impressed by everybody's bravery and the kindness that people were showing each other, but the vulnerability that you shared with others in the Dennis Group first meetings, and we'll talk about the Dennis Group at another point, but that was a bringing together of BME nurse, mental health nurse activists to really start to share their experiences. And that was very, very haunting for me about what you were all going through.
Yeah, it's something that I would definitely do not want to repeat again. But with support from all our colleagues, non-BME nursing colleagues, I think we were in a better position, because the mental health is a family. Mental health is a family first and foremost, and you know each other either through training or through difficult times as well. So I think the country itself has a different relationship with when, say, BAME staffs are having going through their own challenges. But I think within the actual profession itself, colleague to colleague, there's far more comradeship. Yeah, we're in it together, and there was that level of support in around trying to debunk fake news, trying to decipher fake or poorly advised people to present different ways of coping with the viral infection. Take these herbal medicines and do all of this stuff. So there were some colleagues going to work feeling empowered, because they've taken some of these these solutions. I say they're not even medicines, these solutions, but contracting COVID. So I'm having all these conversations. I'm trying to ensure that the right news, the right information is getting to the right people. But in those, particularly the first 6 months of the pandemic, it was rife in terms of these remedies, these fake remedies, and that didn't help further. It didn't. I think it put people more at risk because they felt that they were impervious and they were able to work in environments whereby they should have had PPE, the right sort of PPE anyway. And on top of that, still observe the social distancing, hand washing, and all the national guidelines that were there.
Well, I remember the challenge, and it still is the challenge for all of us as mental health nurses, not getting clear guidance. And I'll get the opportunity to talk a bit with that as well with Roland in the next interview. But I just wondered how, you're thinking about what you've talked a bit about the forms of support you received, but do you think, what other forms of support do you think was available to you?
I think my support is maybe different from the broad the broad number of other nurses there, because I have a rich network in terms of the work I do within the RCN, both yourself, Catherine, and the stuff we do with the Zim Healthcare Association. So, and my own family, we're very supportive. You know, I come from a family of nurses. So we share that conversation and we have it in a very brutal way and we make decisions. So when I was asked in that interview, would I prepare to stop working as a nurse? I said, yes, I am confident in doing that, because I'm not looking to pass a virus to my immediate family. I came into the profession to add value, to help people in need, to empower them, to give them back a sense of ownership, and liberate them. You know, that's why I came to this profession. And I think COVID's made me take a step back from that. I had colleagues talking about, I think Roland will touch upon this point. How then do you have a trusting relationship with patients when there's social distancing, but you have to then engage even searching their persons for illegal objects, contraband items, and all those things. So the support I was getting was more to do with my own social family type network. Very little from the agency, very, very little. Just keep your make sure you get your revalidation done. And I still say, and I'll stand by that, that needs to be addressed. When the dust settles, we need to make sure that anyone that comes into the NHS has the right level of training and the same level of access to PPE, because again, at the time, you leave your house going to a shift and you have not been given PPE. You don't know where you're going to get the PPE. If you were permanent staff, you would have had that conversation. But an agency worker, you can go anywhere, any given time. And we were watching news that the Florence Nightingale Hospital was open. So some of our colleagues were asking, is there going to be a mental health unit there? Because we've worked in liaison psychiatry, and we know in busy A&E departments, and you're still going to be presented with a lot of mental health issues that go hand in hand with what's happening physically as well. And if you cannot calm somebody down or get them to think a bit more objectively, you know, that can increase their heart rate, increase their problems with breathing and all those things. So yeah, I went off at a tangent there, but I still believe that a lot more definitely could have been done. Lessons definitely needed to be learned from that experience.
Yeah. And I just spotted some comment in the chat box, somebody saying that, you know, there's resonance around agency, and that there was so much miscommunication about fit testing, so much and the process of how you access that. Just thinking back, you know, I'm just wondering what reflections you've got on those last. I mean, we're nearly a year in now, and I just wonder what sort of reflections you've got in addition to what you've talked about already.
Okay. As I'm reflecting, we're still living it, as you quite rightly said. It's a year in and it's still here. It's how we move. What's going to be the new norm moving forward? How are we going to restructure our mental health services so that we can better take care of people that are presenting with COVID? How are we going to train the future nurses? How are we going to think about dual training a lot more, topping up on physical health training so that we can feel competent to address physical health problems, and vice versa, and vice versa. I feel it's opened up and exposed for me the use of technology to help support what we are doing. And now I feel more confident now that we need to engage with people on their own terms. The pandemic has demonstrated when you cannot physically get into somebody's home because they're shielding, you can still communicate. We have this term called telehealth. You know, it's been around for like 20, 30 years, telehealth, you know. I'm delivering care via television, essentially. That's how it was. At least that's how it came about. But now we've got smart technology, smartphones. We've got so many ways we can reach out to people. And the one thing I would say for myself is being able to reflect back in a way that you don't blame yourself. You know, self-blame is because you get pressure, particularly if you turn down a shift or you don't want to go to work, or you don't feel confident to go to work. You know, you shouldn't feel guilty for not going through to work, going to work. It's up to governments, it's up to leaders to ensure that they have enough staffing in the event of these things anyway. Sometimes we take in the ownership and the authority and the responsibility too much, because as every single nurse is a manager of their own care, is a leader of their own care. Anything goes wrong, you know it's going to be on your pin, on your registration. But I think that for me, it's being able to step back and say, actually, I'm not competent enough to risk myself in this environment, because when I'm going to be working in this environment, I'm not going to be delivering the best care possible, because I too have my own needs, and those needs need to be addressed. So yeah, I am now more in tune with my emotional state, more in tune with my feelings. I'm more in touch with my colleagues, and I'm positive that we can, as long as we're able to appraise and look back, and not afraid to look back. Yeah, not afraid to look back, meaning we look back in a positive way, but not in a way that we look back to point the finger. Because this came at an oblique angle. Nobody really saw it coming, you know. So we need to be able to look back in a very positive way and put in place the right support, update our skill set. There's skills now that I have that I would not have had if it wasn't for COVID. You know, so I'm trying to be a bit more positive and pragmatic about it. That's the best I can do.
You are being. I think that to just summarise, for me, there is something around the learning in the process, and also for me around actually how to support. When we talked previously and prior to this interview, we talked about the forums that men have to share their experiences, and you know, you talk very much about how do you share your vulnerability when the pub's shut, the football pitch is closed, that all the places that men would talk to other men about feeling vulnerable were all shutting down.
Yeah, absolutely, and that's terrifying. Again, you couldn't make it up, and a lot of male bonding, a lot of male support comes in around banter, even around football, because we don't fly direct with our feelings and emotions. Because when we do fly direct, your friends are like, oh, whoa, what are you doing? What are you doing? It's too heavy, man. That's something that men needs to, generally speaking, need to readdress. There's no harm and there's no shame in being able to express how you truly are feeling. And I think if you have any kinship with and friendships, they should be able to reciprocate that and be ready to listen. And I think for me, it was more to do with listening, because you cannot suddenly expect somebody to know how to communicate feelings that they've never communicated before. You know, like for example, being the male person, say for example, being male, and you have the stereotypical pressures to always be knowing, supportive of the family, all of those stereotypical roles.
Yes.
All of those things will also come into question, because if you're the perceived man of the house, but now your wife is going to work, how then are you feeling? You know, how then are you feeling? You know, so there's a lot to do with understanding how to express how you're feeling, not feel guilty for having the thoughts that you have, and listening. For me, the fundamental skill that I've really learned is just to listen, hang in there, because I had friends of mine, even on the Zimbabwean Nursing Association, they speak to me, and I'm so quick to get in there with, do this, have you tried that? Just be quiet, Douglas. Tell me to just be quiet and listen. Just listen. And over time, people will start expressing how they truly are feeling about something. And that was profound. I've known it as a professional for years, but in a male bonding experience for my friends, that's been something that's been new. I've never applied any of my therapeutic skills with any of my friends outside of work. I've never done it, but I found myself sitting down and just listening. Yeah, when there's no football, no music, there's no going out to a pub, there's nothing. So when your friend calls you, you have to listen. And they will try to make up news that doesn't really exist, but you still have to sit there and listen, not judge. You know, so yeah, wow, yeah. And so I'm looking to build upon that, and any male groups that form from such a pandemic is only a good and powerful thing, because let's be honest, these stereotypes, they're not useful anymore. They have no validity anymore. They're doing more to harm young men in particular, because like for the example, the rate of male self-harm is almost in line with young girls self-harming, and in some places even possibly surpassing that. Why is that? You know, what are we going to do with these emotions that we have, really? So it's a big question, and I think something that has definitely been quickened by the whole pandemic.
Thank you. I realise that we need to go on to talk to Roland now, but I want to thank you, because I think quite a lot of what you've talked about, Douglas, will be so easy to transfer and to actually use with our patients. The importance of listening, the actual providing an opportunity to recognise that actually space and that quiet time when people are alone is so vital in our therapeutic activities of mental health nursing. Thank you for your honesty, Douglas. As usual, as somebody seems to have just said in the chat, you are an inspiration and very honest, and I really appreciate what you've just done.
Oh, thank you. Thank you very much. Thank you.
I'm going to come to Roland now. Oh, here you are. Good. And Roland is still at work. So just to pick up on some of the points that Douglas has made, again, we had numerous conversations at the very, very beginning of COVID. Roland, you were pivotal in helping my understanding of the particular issues that our patients and staff were experiencing in intensive care units, and through your work with NAPIQ. Just give us that hit, that first memory, and just talk us through.
Well, yeah, well, thanks for the opportunity, Kath, to come and talk. So I'm very grateful for it. First memory of COVID really is I'm an avid watcher of news, and I'm one of these people that's always got the news on, and I like non-mainstream news like Al Jazeera and CNN and so on. And I remember seeing this thing unfold in China, and I was particularly struck by the citizen journalist who was filming outside of his window in Wuhan, and somebody had died actually in the road that he was captured on the film. And then he spun round, and there were officials welding up the doors of an apartment block to try and contain and control the occupants who presumably had this new infection. At that point, I thought, this is serious. But I also thought it's probably not going to arrive here, because SARS and the bird flu and other scares have not materialized in the way that we thought it might. So I had this sinking feeling, this can't be good, but somehow it was going to be okay here. So that was probably my my first thought. And
so you obviously heard of the pandemic on the news, but how were you alerted to the outbreak? And tell us that, you know, when it started to come nearer home, what was your initial reaction?
Well, I suppose that it was creeping up on us in a way that we couldn't really avoid, and sooner or later you could only be aware, you could see it. And I was very struck by what happened in Lombardy in Italy, and they had a Sky News account of the intensive care unit there, and that then became very scary. I was actually at the Cheltenham races not long after that happened, in amongst 200,000 people, knowing as a healthcare professional this is probably going to be a pandemic and come our way. And then obviously the news took on a momentum within this country, and it became very clear that we were going to be facing this issue. And within my own organisation where I work, slowly that things that would usually in the bureaucracy of the NHS take years to achieve were being achieved in days. Redeployment of community mental health teams, wards being pretty much emptied wherever possible for anyone that could go home, should go home. And then I was starting to realise that I'm a nurse, but I'm also the responsible clinician as a non-medical responsible clinician in our forensic unit, and I'm the clinical lead for our PICU. And then it suddenly dawned on me and others, well, how are we going to cope with this? Well, what's going to be the human cost to both staff, patients, and the community of our hospital? And then the next thing that started to happen were increasing WhatsApp messages and emails saying, so what are we going to do then? What is the guidance going to be? How are we going to navigate a way through this? So myself, colleagues within that PICU, multi-professional, multidisciplinary, with service user input, started to scratch our heads and think, well, if someone's COVID-19 positive, and unable or unwilling to cooperate with isolation and so on, what would our response be, and how do we operate within that in that space? Starting with a very naive assumption that this is a respiratory disease, so presumably everybody will be in the general medical hospitals, and if you've got this virus, you're not going to be very active within a unit. At that point, we didn't realise just how many people would be positive and physically very able. So that was it felt like 4 months, but actually in 4 or 5 days, we got about 30, 40, close to 50 in the end, I think, people together to put together a set of guidance. And the two things that scared me, there were two things on polar opposites of the equation. One was, are patients going to be locked up all around the country in seclusion rooms, in extra care areas, or in their own bedrooms? Are we going to throw the code of practice out the window in our fear? And the other side of that coin was, how many of us, staff and patients and others, would have eventually succumbed to the infection? So it was trying to navigate a path through, and for me anyway, you really have to revisit your first principles. What are we here to do? How important is it? And what is our responsibility towards? It became more about people and less about patients and staff. And finally, my thought on this was, why us? Why me? How will this come to visit us in the mental health estate, certainly in the inpatient estate? And then I thought of colleagues there at the general medical facilities doing their bit. And then it occurred to us, this is our place. This is what we need to do. Keep our people safe, ourselves safe, and carry on delivering mental health care. So they've got their part, and we've got a different but equal part. Yeah, so those are I suppose that was the highlights of the initial impact anyway.
So how were you and colleagues feeling? I mean, my first thought to everybody in secure environments was to put my feelers out and say, where are we? And the Mental Health and Learning Disability Nurse Forum was full of people asking how, what, who's doing what about PPE, using language I hadn't a clue what they were talking about most of the time. And my RCN colleagues who were infection control knew exactly what it was all about, but I didn't know what, as we said earlier, donning and doffing meant and how on earth we do that. And there didn't seem to be very much at all, well, in fact, nothing for mental health. And I remember as the RCN lead getting really scared for our members around actually what that, and you were pivotal in helping me have those discussions. And we were with the Department of Health, around with you and with the Royal College of Psychiatrists, and we went together with our colleagues from Unite the Union, and we pulled together as much as we possibly could, but it was still, we didn't know what was going to be safe. So just, do you mind just talking us through how that was unpicked by you and your colleagues?
Well, first of all, you know, we were all we were scared. We were scared. As I say, I'm the RC in a forensic unit, and people's parents were ringing up saying, I've seen on the news that in some places around the world they're releasing prisoners, so please send my boy home. You know, he shouldn't be there. So fear was a real issue. For the staff team as well, we felt fearful. I remember the first sort of ward round on the second day or third day of lockdown, we were looking at each other and seeing different people, because we weren't seeing patient, we were seeing, we really need you on board with us because otherwise we can't proceed. And the patient was looking back at us saying, I hope you guys know what you're doing, because I can watch the news the same as everyone else. What became really clear with the PPE issue, and like you, Kath, I went on a very steep learning curve as to what all this was going to add up to. And there were some people thinking we ought to be in the equivalent of spacesuits in order to be protected. There were others thinking, well, actually, you know, you're not got aerosol generating procedures, therefore you don't really need anything. And what became clear to me very quickly was the IPC specialists were well-intentioned, well-informed and expert within the controlled environment of a general medical facility, but there was zero to little knowledge of how beyond the normal sort of norovirus and other issues that are attached to mental health facilities, there was no way of translating that knowledge into the reality and daily existence in a general adult intensive care or forensic mental health facility. So it felt to me like it wasn't so much that the mental health nurses and people met initially with our IPC specialist. We collided. There was a collision. You guys need to do this. You need to wear aprons and do this and all that. And then in a general adult facility or a forensic or PICU facility, aprons very quickly become a slip hazard. They become a choke hazard. The mere look of everyone in that environment could cause and escalate situations. So it became clear that we'd collided rather than had got in the same vehicle in order to take it forward. And then I suppose the real learning happened. We got round the table again, IPC specialists in our own trust and around the country with mental health specialists, and started processing the realities of each situation of engagement of the ward community and activities and so on, and making the IPC wisdom attach itself to the mental health wisdom in a way that things like PPE and infection control measures could make sense. So that was our starting point, a new relationship. No longer does one tell the other what to do. We're in mental health, we know it all, you guys haven't got a clue, and the other way around. How do we put this stuff together? So it became clear that no one knew that we could find it nationally or internationally. If you involve yourself in physical intervention with someone, you know, it's a way of sanitizing what is restraint, really, in very desperate and serious situations. What does that mean in the infection control agenda? So we didn't want spacesuits, nor did we want to be completely unprotected. So through our literature reviews, nobody seemed to know. So we designed an experiment with our IPC specialists of tracking the transfer of UV material from a person who is having the procedure of PMVA, which is one of the physical intervention procedures applied. How much infectious material potentially moves from one person to another, and what kind of PPE is less likely to result in more transfer of infectious material. So far as we knew anyway, and no one so far has demonstrated otherwise, we didn't think it had ever been done before worldwide. So we set up that experiment, and we had to do it all night to get the UV photography conditions. and we used the same tomography that's used in CT scans. A friend of ours, Dr. Pete Metherall from the 3D imaging laboratory at Sheffield, to analyse this very controlled data. And then we thought we at least for the first time knew roughly what PPE was reasonable or unreasonable, preferable or not preferable in those scenarios.
Well, and I think that was the point for me where you and I had started to have those conversations, and how I was almost on the knife edge waiting for the results of this. And I know that you're saying now there is a paper coming out. Do you want to just say a bit about some of the outcomes that you've mentioned for the record?
Indeed, yeah. I mean, the outcome of the paper's being published any time now. It's been peer reviewed, published in Medicine, Science and the Law, the journal, the Forensic Journal, and it's it'll be out any time soon. The actual conclusion, so far as practice is concerned, is included in the NAPICU guidance, which you can get through the website.
Yeah.
Then it surprised us, to be honest. I think many people in mental health believed that we would be absolutely covered in UV material showing infectious transfer. And I think many people on the other side of that equation felt there wouldn't be a lot of transfer potentially if you had the right PPE. The reality is it was in the middle. It was less than people who engage in the mental health inpatient estate was expecting, but far more than possibly some of our IPC colleagues would have predicted. The patterns of transfer were very similar, which was interesting. We didn't expect that. Also, the PPE resulted in a lot of protection against transfer, but there was a lot of residual, more than we would have expected in the neck, in the face area, because we simulated a spit as well, using a spit simulation through a bottle. And there were procedures that didn't exist so far as we could tell in the general medical fraternity of face and neck cleansing and hand cleansing post-intervention that were obviously necessary because of the amount of material that moved. So for those that are interested, if you go to the NAPICU website, you'll see the national guidance on engaging with acute disturbance and what we think we've learned in terms of practice and practice development is included in that document. I mean, the final thing I'll say about that is when people were dressed in different PPE, undertaking physical intervention, the one thing that struck us all, if you were a patient who was distressed, frightened, hostile because of your pathology that you were experiencing, and you were faced with people aiming to physically intervene with you dressed like some of the equipment, certainly the coveralls and goggles, what a frightening situation that would be. So it was very necessary actually that we try and find some evidence to make this a better experience for everybody concerned. So it wasn't just about protecting staff, actually, it was more about improving the situation.
Yeah, yes. And I've just seen somebody saying on the chat that they didn't get the paper's name, and we can share that. And obviously you'll be announcing it via the NAPICU website, which again, the mental health clinical topic page, we've got links to the RCN mental health clinical topic page, as always, from very early on, had those links so that we could make sure that we were together on the same message. I think for me, the lasting image I have of you, Roland, is you're wearing a uniform.
Yeah.
And I know that, that was another big turnaround for many mental health nurses who got in contact with me and, should I wear gloves? Should I be wearing? And really what the ultimate answer was around, we have to have above the elbow, wash our hands, remove our jewelry, take off, be very clear about the infection control. But I just wondered whether you want to, how have you got over the myths and misconceptions that you have to wear gloves all the time and that you have to do this or particular? How have you done that?
Well, Catherine, you may know, actually, prior to COVID, I'd be one of those that would be speaking at conferences or trying to persuade people that the infection control agenda had gone over the top in many psychiatric facilities. I used to even say that, you know, the schizophrenia spores are developing in the carpet.
I think I remember being at a conference while I heard you say it.
Indeed, in many mental health facilities, a carpet, for example, can have a huge effect on softening the environment, managing the acoustics. So many of our mental health facilities got stripped out, I think, not always because of infection control issues, but often. And I felt it had an unhelpful consequence in many ways. Strangely, because of all the research we did in studying the evidence related to COVID, carpets and fabrics are far less infectious, it turns out, than many of the hard surfaces. And I've been a big supporter of non-uniform. I believe it encourages people to take people out on escorted leave. It sets a different example in terms of hierarchy. And I felt the uniforms were not helpful. But here I am sat here in scrubs. But I think what the uniforms did for this pandemic is focus our minds on infection control, the balance. This is real, this is serious. Well, I'd like to see them go though, as soon as the pandemic is over, because if I were to escort somebody, I mean, the town's not open, but when it is open, this isn't very encouraging to walk into town with somebody and go shopping or to engage. So, yeah, so that would be a sort of a general view of those issues.
Yes, well, I think it's just useful to reflect on, because I would be of the same ills. So, looking back, can you share your reflections? I think there's something really powerful about what you said about becoming people. Well,
indeed. I mean, what have we learned from this, and what should we continue to exist with beyond this particular pandemic? Well, when we were all having to stay at home, we weren't allowed out. We could only go here with one person or here with the other person. I'm an RC and I fill out what they call Section 17 leave authorizations. You may go to this place, zone 1, for this amount to meet this person or go out with your mum on this day. Suddenly we were all on a section. We were all together. The rules, I'd sit with people in my secure facility watching the news, waiting to find out what we could all do next. Not just they, but we all. And we had to depend on each other far more. I mean, we did this little BBC thing where one of our guys in the forensic unit, who was a restricted person, was able to speak out about not being able to share a meal when you live together as a community in a forensic unit, and having you leave, you haven't got much as it is, and not being able to go out and enjoy the bits that you did have. So we all became people, I think, and we all had to depend on each other more so than we ever thought we would. So that was good. In fact, our doctor here, one of the specialty doctors, published a paper about that, you know, the more philosophical side of COVID. So I think we learned that. For me, the bureaucracy just, for a while anyway, disappeared. Suddenly, lots of people and agendas that had penetrated virtually all manner of existence just evaporated. Lots of people were working from home that, you know, otherwise would be sort of emailing and doing stuff. And suddenly the conversations changed, the agenda changed. And if it was a good idea, you could get it done. Yes. Even with procurement, we needed televisions for we needed PPE. I was even in Screwfix at one point buying their coveralls and goggles. Everything became easier. God, we should preserve that. I suspect the bureaucracy will be back. Too many livelihoods depend upon it. And so I'd like to see the people angle preserved. I'd like to see the new cooperation across the nursing disciplines and multidisciplinary, you know, that nobody has the monopoly on wisdom. We have to learn from each other. And an inpatient mental health environment is a unique place that deserves its own evidence and its own understanding. So I'd like to preserve that. bureaucracy can stay gone as far as I'm concerned. I suppose the final thing, it's healthcare, because it's the healthcare professionals and systems around the world that will have to pick this up. It seems to me, you know, Mother Nature fought back for the first time. We've been cutting down too many trees, putting too many bats under too much pressure so they don't heat up when they fly, which is how they manage their immunity with the viruses, colliding animals together through mistreatment. Then we've got global warming. Mother Nature has fought back. And I hope we can remember that, because it'll be the healthcare professionals and the least advantaged on the planet that will suffer these consequences. And anyone who's dedicated their time or life or career to healthcare ought to hope that that message stays with us, that Mother Nature's had enough, really. Yeah, a bit philosophical, but yeah, that's what I put forward.
Well, I think that's a fantastic way to finish, Roland, and just the way that you've reflected and the humanitarian element of being a mental health nurse in the time when we really haven't had an opportunity to really shine a light on what we do. You doing it, and I want to personally thank you for what you did with the PPE and actually helping me to make sense of it. And you've really just demonstrated to me why you are an RCN fellow. And the Royal College of Nursing is you know, there are very few mental health Royal College of Nursing fellows, and I am delighted to know, I say, I've just interviewed one. So thank you so much, Roland.